Greetings, Patho students, and welcome to week 6. We're going to start on unit 6 in the ebook, and that gets into respiratory function. We have 3 chapters to cover. One is chapter 21, which is control of respiratory function. Chapter 22, respiratory tract infections, neoplasms, cancer, and some childhood disorders. And then chapter 23, disorders of ventilation and gas exchange. Chapter 21, typically I'll say that, we always start off with a review of the system and review, in this case, it's review of the control of respiratory function. And I always say, so go over this if you need it. If you remember any of this from physiology, you may be able to gloss over this. In this case, chapter 21 seems on the heavy side to me. So I'm going to point out a couple things that I want you to focus on, obviously, in this focus video, versus some things that you can skip over from my point of view. We're going to look at what are the functions of the respiratory system, and a good overview is figure 21-1 has a good overview of the function of the respiratory system and all the anatomical pieces that we rely on in our respiratory system in order to get it to maximum potential here. Looking at the respiratory airways in figure 21-5, which goes over the blood supply to the lungs, and then figure 21-7, which goes over the actual alveoli, takes us all the way down the respiratory tree to the level of the alveoli and the pulmonary capillaries that lie there. Moving through the chapter, do watch, there's a video called Change in Breathing Sounds, and that basically is a reminder of when we, of course, are assessing a patient, we're going to listen for breath sounds. And this is a reminder of what's responsible for what sounds. What airways are you listening to? Are they coarse breath sounds? Are they fine? Are you listening to the actual exchange of air? Are you listening down at the alveolar level? Also, I want you to go over the difference between atmospheric pressure and partial pressure, and identify factors that influence both the atmospheric pressure. We're talking about how the lungs work, and obviously it's an involuntary reaction, and so we're going to look at all the different factors that actually make us breathe or make us respire throughout our entire lives. Look at the differentiation between pulmonary ventilation and alveolar ventilation. So ventilation has to do with movement of air, obviously. Figure 21-9 talks about the pressures within the lungs. I want you to look at the alveolar pressure, the intrapleural pressure, and the intrathoracic pressure. Because as we start to, and that is, you'll get a good depiction of those 3 different pressures in figure 21-10. As we start to look at the different disorders of the respiratory system, we'll see how those pressures are affected by some of these various disorders. Also, figure 21-11 goes over the muscles in the breathing cycle that are required for us to ventilate, and the respiratory muscles that affect ventilation. You can skip over lung compliance as far as I'm concerned, and then move on to lung volumes and how we measure lung volumes in what's called pulmonary function tests, PFTs. Table 21-1, this is table 21-1 versus figure, goes over helpful definitions of a variety of pulmonary function tests. There's a table prior to that that defines all the various pressures, but I think it's more meaningful for you to look at the name of the actual test, what it measures, and then you could see how that would help us diagnostically determine what a problem is with the patient. Those definitions, also table 21-2 has those various pulmonary function tests. I want you to watch the video as you move through the chapters on gas exchange in the alveoli. These videos are short, as you know, they're 3 to 5 minutes. Gas exchange in the alveoli, how oxygen and carbon dioxide move across the alveoli and make it into the pulmonary capillary circulation. In this area, we're going to talk about ventilation versus perfusion. This is a little complex, but to be able to differentiate dead space from shunting. So one of our pulmonary function tests, going back up to a previous table we just looked at, is a ventilation perfusion study. We call it a VQ study. V stands for ventilation, and I'm not sure exactly what the Q stands for. I don't really know. I'm sorry. It could be a Latin word for perfusion. I don't know. But we refer to it as a VQ study, which is a ventilation perfusion study. So we can see how much air a patient is taking in and how well the organs are being perfused. So it's one thing to be able to exchange air. It's another for that air, oxygen, to actually do what we need it to do, which is to perfuse our vital organs. And for that, I'd like you to refer to figure 21-16. Every once in a while, I'm going to bring your attention to what we call in this book misconception alerts. Some of them are more important than others, but I think this one is pretty important. It's a misconception alert, meaning many students have answered this question in Prep U incorrectly. And it has to do with arterial versus venous blood gases. So just open up that little box that says misconception alert for arterial versus venous blood gases and take a look at that and see if you can say, oh no, I understand that, or oh yes, I probably would have answered that question incorrectly too. Really important to focus on this, which is the oxygen partial pressures and how they can predict oxygen transport in the blood. There's a video on oxygen transport, and I'd like you to watch that video. And again, that's the transportation of oxygen. Then the very next section in the chapter is the transportation of carbon dioxide, and the same thing occurs. How can we use CO2, carbon dioxide, partial pressures? This is what we get as a result of arterial blood gases. How can we use CO2 partial pressure to predict the carbon dioxide transport through the blood? Moving on, more important stuff. Identify the components of the respiratory center. What part of our brain actually causes our lungs to signal them to breathe? Look at figure 21-18. And I want you to differentiate chemoreceptors from baroreceptors. Chemoreceptors react to oxygen and CO2 levels in the blood. Baroreceptors, baro, like a barometer, baroreceptors react to pressure. And I don't know that this chapter actually calls them baroreceptors. As we move through the following chapters about disorders, they do refer to the baroreceptors. The baroreceptors, as defined in this chapter, are called the stretch receptors, the irritant receptors, and the juxtacapillary receptors. I don't care that you know all those different ones, but I do care that you understand the concept of a baroreceptor versus a chemoreceptor. And then also understand in this area, read about the cough reflex. What is it? How does the cough reflex happen, and what does that do for us? How is that important? So that is chapter 21. Chapter 22 is respiratory tract infections, neoplasms, and childhood disorders. So you know we're going to talk about cancer here as well. But first we're going to start out with the common cold. Viruses that cause the common cold. So there's many for us to study. I want you to focus on the common cold because that will overview how that virus is transmitted, which is the same way all these respiratory viruses are transmitted. And then also the influenza virus, influenza A, B, and C. Why is it important for us to get our yearly flu shot? So look at those two viruses, in particular the common cold and the influenza virus. Moving on to something that really relates to hospitalized patients is pneumonia. So in this section about pneumonia, you'll learn to differentiate community-acquired pneumonia, which means exactly how it sounds. Community-acquired, it means the patient acquired that pneumonia out in the community somewhere, versus hospital-acquired pneumonia. The patient came in for something else, and in the hospital they acquired pneumonia. How does ammonia affect immunocompromised patients or persons? The big problem underlying here, we don't talk about the healthcare system in America or the finances of healthcare very much in this class, but just so you know, I can start to plant a seed. For those of you who don't have any clinical experience, hospital-acquired pneumonia is considered a hospital-acquired infection, an HAI, and once you're diagnosed with a HAI, it means that Medicare will no longer reimburse the hospital for the care of that. Whatever you're in the hospital for to begin with, your problem A will still be covered and the hospital will receive compensation. But the meds, the treatments, the nursing care, the specialists who all get involved with a patient who's been diagnosed with hospital-acquired pneumonia, none of that will be compensated. So what do you think is going on inside the brain of the CEO of the hospital? We need to do everything we can to prevent hospital-acquired pneumonia. And there are tons of things that nurses do with or without orders that can help prevent hospital-acquired pneumonia. The most likely candidate for hospital-acquired pneumonia is someone who's immunocompromised and someone who has had surgery. A post-operative patient is at higher risk for this hospital-acquired pneumonia. And just between you and I, this is why if I have a loved one in the hospital, I want to get them out of the hospital as soon as possible. If I'm ever in the hospital, I want to be out of that hospital as soon as possible. And that should always be our goal. I also want you to read about primary tuberculosis. Tuberculosis is a big problem in the world. It's not as big of a problem in our country, but that's only because we have immunizations and we have testing. If you're in healthcare, you are required to be TB tested yearly. So I want you to read about tuberculosis. And then there's the next section following tuberculosis is about fungal infections. There are many. The only one that really is prevalent in Arizona, which is where most of you will likely practice, is what we call valley fever or San Joaquin fever. And it does refer to it in your reading, but not by those names. It refers to it, we call it cocci, C-O-C-C-I, because the real name is, bear with me, coccidioidomycosis. Coccidiomycosis. And I might be leaving out a syllable, but that's why we call it valley fever. And that is a fungal infection, and that spore is actually found in the earth, in dust, in dirt. So if you're working at a construction site, or in Arizona, we're also famous for, I don't know, it's the haboobs. The haboobs are the monsoons where the wind picks up the dust and carries it through the air. We are all susceptible to it, so you can be in perfectly good health and still come down or get infected with this fungus. Our pets can get infected with the cocci as well. So I do want you to read about that. And then moving on, what are the basic lung risk factors for lung cancer? Risk factors for lung cancer. And if you read enough about lung cancer, I want you to be able to answer this question. Why is the survival rate for lung cancer so low? So deep read into this area to answer that question. Why is the survival rate for lung cancer so low? Move on. You're going to go over some issues about children. You don't need to look at that in this chapter. We'll look again in the further chapters. But I do want you in this chapter 22, read about the treatment of respiratory distress syndrome. And basically, what is the definition of respiratory distress syndrome? And again, back to children, most likely children are affected by this disorder called epiglottitis. And this can be potentially fatal if the epiglottis actually swells to the point where it closes. Adults can get epiglottitis. It's very rare. This is normally considered a childhood disorder. So that is chapter 22. In chapter 23, this is disorders of ventilation and gas exchange. So here I would like you to differentiate the difference between hypoxemia and hypercapnia. Hypoxemia, insufficient oxygen in the blood, and hypercapnia is abundance of CO2 in the blood. I'd like you to know the definition of cyanosis, and moving through disorders of lung inflation, look at the pleura. What's the definition of the pleura? You have three different pleurals. Well, you have two basically in the lung, the parietal and the visceral, and then we have the pleural cavity or the pleural space. So I want you to know which is the parietal pleura, which is the visceral pleura, and then what constitutes the pleural space, because problems can occur within that pleural space. What is the definition of pleural effusion? The definition of hemothorax, and then tension pneumothorax. Hemothorax, break it apart. Blood. Blood in that pleural space. That's a hemothorax. Tension pneumothorax. Well, first of all, there's a pneumothorax, which is collection of air in that pleural space. A tension pneumothorax, you'll read about it, is much more serious and is also deadly if there is no intervention, and that typically is a result of trauma. So read about a tension pneumothorax. What is it and what's our intervention? Then cranking it back down to is atelectasis. Atelectasis. What is atelectasis? I'm going to tell you it's a precursor to pneumonia in many hospitalized patients. So read the definition of atelectasis. Then we're going to move into some disorders that also affect children, and one is asthma. So there is an asthma video on Canvas that I pulled from Khan Academy. I like it because I like the way he draws the bands around the tubules and the alveoli. I just like the way he explains it. But there's also a video in your ebook about asthma. So watch that one as well. So this is in a section called obstructive airway disease. Very often now asthma is also referred to as reactive airway disease. So sometimes you'll see, you know that somebody has a history of asthma, but when you read the H&P, the history and physical, all you're seeing is reactive airway disease. They're referring to asthma, meaning there is a trigger that's causing a reaction, causing these airway problems. I also want you to read about there's a whole section on quick relief medications and long-term medications. And as you get into nursing programs and you read about the care of patients having an asthma attack, there's a lot of patient teaching that is involved usually with the medications. Very often, asthma patients are using their medications incorrectly. The long-term medications are medications that are taken every day. You wake up in the morning, you don't have any symptoms of asthma, you take your medication anyway. And that will keep you or prevent you in many cases from having an asthma attack. So it's important that patients understand this inhaler is for when I'm having an asthma attack. These pills over here, and possibly an inhaler as well, are to be used once a day or twice a day, every day, regardless, even when I'm not having symptoms. So understanding exactly what asthma is, if you watch those two videos, they'll give you a good understanding. Then moving on to COPD. COPD is like an umbrella, chronic obstructive pulmonary disease. And under that we have chronic obstructive bronchitis, and we have emphysema. Clinically speaking, it's very difficult, very often, for us to differentiate. Does this patient have chronic obstructive bronchitis or does this patient have emphysema? That's why we kind of throw everybody into the big barrel called COPD, chronic obstructive pulmonary disease. There's a video for you to watch about this one as well. And then you'll see in figure 2310 some of the distinctive physical characteristics that you can find on assessment to help bring you towards that proper diagnosis. In particular, there is a depiction of a patient with what we call a barrel chest. Because of the difficulty breathing over time, it actually changes the circumference of the rib cage, and the patient develops what we call a barrel chest. So I want you to read about that physical finding in this area. Moving on, do a quick overview of cystic fibrosis. What is the nature of that disorder and what kinds of problems does it pose? And then getting into interstitial lung disease. So this is no longer airway issues, but issues with the actual lung tissue, interstitial lung disease. And there's a table of causes in this chapter, and the causes can be environmental. They can be brought on by reaction to, in some cases, chemo or some strong antibiotics, which is very sad because those patients need those medications. We never intend for this to wreck their lungs, but in some cases it does. It can also be as a result of an autoimmune disorder, where you've got an autoimmune dysfunction causing an actual interstitial lung problem. So of the very many that are depicted in this area of the chapter, I want you to look at sarcoidosis. Sarcoidosis as an example of an interstitial lung disorder. Then as we're getting to the end of the chapter, this is some more exciting stuff. Pulmonary embolism, which is a clot in the lungs, a blood clot in the lungs. What is a pulmonary embolism and how does it get there? What do we do about it? What is pulmonary hypertension? A different kind of a disorder. This is a chronic disorder. And again, sometimes this can develop as a result of medication or some other kind of chemotherapy. And then wrapping up this chapter, please pay attention to acute respiratory distress syndrome, ARDS. ARDS. Very often, this is what patients in the ICU on ventilators are diagnosed with because they've had acute respiratory failure. They actually have, their lungs are unable to either ventilate or perfuse. They need ventilation or mechanical assistance. I want you to look at the causes of respiratory failure in chart 23-3. And that's all I have for you for week 6. Please email me if you have any questions about week 6 content. At the conclusion of week 6, you should be ready to take course exam number 2, which you'll find under the Prep U tab on the point. Course exam number 2 covers content for weeks 4, 5, and 6. I hope you have a good week. Thanks.